Thanks for joining us for a special webinar answering your questions. This webinar features the presenters from our Spring Education Summit, answering more of the great questions that were submitted that day. I'm Kelsey Morrow, Education Manager at the Rocky Mountain MS Center, and I would like to thank the pharmaceutical companies who have provided support for this program. Thank you to Bristol Myers Squibb, EMD Serono, and Novartis Pharmaceuticals. This series is just one piece of our education programming. We have a variety of formats available to you, including both in-person and online options, with most of our programs also available on demand through our YouTube channel. Today's questions were submitted at our Spring Education Summit, which is fully archived on YouTube. The topics covered were understanding MS progression, brain volume in MS, weighing the risks and benefits of medication, and what's new in MS research. Plus, there were 2 Q&A sessions that day as well. If you like this Q&A format, please check out the series called Conversations on MS, which is a 90-minute town hall style Q&A with the MS specialist neurologist from the Rocky Mountain MS Center at University of Colorado, and includes a clickable index of topics. We announce upcoming educational opportunities through our mailing list, our Facebook page, and you can sign up for notifications through Eventbrite. All of our education programs are free of charge to anyone interested. Today's video features Dr. Enrique Alvarez, Dr. Terry Schreiner, Dr. Robert Gross, and Dr. Ryan Kmeyer. All of these doctors are MS specialists providing patient care at the Rocky Mountain MS Center at University of Colorado. This presentation is for educational purposes only, and all treatment decisions should be discussed with your own neurologist. With that, I'll turn it over to Dr. Alvarez to start us off. So can you tell us, are most foot drop and hip flexor weakness symptoms due to lesions on the thoracic spine?
Yeah, so when we try to localize symptoms in MS, it can be a little bit challenging. So traditionally, we would say, symptoms in the legs, such as the foot drop, leg weakness. The main place we would look for is in the lower spine, in the thoracic spine. The challenge a little bit is that MS lesions can be a little bit tricky and a little bit small. So not to get too technical, but I think it's kind of interesting just to kind of talk a little bit about how we think about things. The way, for example, that sensation occurs and is relayed from the legs to the brain is the leg information kind of gets put sort of in the middle of the spine. And then as the fibers coming up come in, they get added on the sides of things. So if you end up with a spine lesion in the neck, in the cervical spine, but it happens to be sort of like right in the middle, and it's not very big to kind of expand into the arm areas. It's going to give you symptoms in the legs because that's where the fibers for that hit. And so it is possible to have lesions in other parts of the spinal cord that, higher up where you could end up with predominantly just leg symptoms. So, the opposite's not the case, right? So arm symptoms cannot come from things lower down because those fibers haven't joined up. And so that's part of the reason where sometimes with the leg stuff that we end up having to do MRIs of the brain, the cervical, and the thoracic spine, just to kind of try to make sure that we're not missing something. If it's both arm, both legs, that usually means spinal cord, less so brain, because then they get split off and kind of go into different directions for the brain. But trying to just get a sense for where things kind of get traveled and where the lesions could be is, I think, sometimes helpful to kind of understand why we're asking for so many MRIs and things like that.
And what about bladder symptoms?
Yeah, so bladder is interesting because the control for bladder really starts at the very front of the brain, and the centers kind of go kind of spotty all the way down to the bottom of the spinal cord. So we do think of bladder control being sort of at the very bottom tip of the spinal cord, but there is parts of that control that go all the way up. The challenge sometimes too, where it can be difficult to see for spine lesions, is that the very tip of the spinal cord is surrounded by all the nerve roots kind of around it, and it's surrounded by spinal fluid. So it has a lot of mixed, excuse me, mixed signal that can kind of occur there, because you have bright spinal fluid and sort of dark spinal cord and nerve roots. And so, if you don't have a really good MRI, which is surprisingly hard to get because it's really small, right? A nerve root is maybe a millimeter or two, so think less than a quarter of an inch, maybe a 16th of an inch or something like that, surrounded by bone, surrounded and signaled by spinal fluid. And so trying to kind of separate all that can be really difficult. So sometimes you can end up with bladder symptoms that are hard to see. And some of the bladder stuff is not necessarily controlled by the spinal cord, but it's damage that occurs from uh, the nerves as they kind of go on the periphery and things like this. You often will hear, sort of, I started having my bladder stuff after pregnancy or things like this, right? So there can be a lot of damage to sort of the bladder system outside of the central nervous system as well.
Based on this, how often do you recommend getting spine imaging done?
Yeah, so we don't do spine imaging a lot. I alluded to one of the issues, and that's that the spinal imaging isn't awesome. So it's possible to miss some things and making it difficult to actually get good pictures of stuff. So bigger lesions we can kind of see, and bigger lesions are a little bit easier to see because then they're big. And so you can kind of tend to pick them up, but they tend to give you symptoms. So the reason why we do so many MRIs is because we're trying to pick up images, your lesions that are not giving you symptoms. And in the brain, that's about 95% of lesions maybe don't give you symptoms. In the spinal cord, it's maybe a 50-50 proposition. But so many more lesions occur in the brain. So recently I heard some numbers that might explain this. So if you're getting MRIs for routine check-ins, so you're not having symptoms or things like that. If you do a brain MRI and that's normal, so you meet those two conditions, the chances that getting a spinal cord MRI pick up a lesion that hasn't given you symptoms is about 2% or less. And so you're talking about doing 3 MRIs instead of one for an extra 2% chance of seeing something. And so just the cost, the amount of time on the MRI machine and things like this, it's a little bit sometimes hard to justify doing all that.
Also, given some of the complexities that you just talked about, um, what are some other avenues that people should be exploring if they've got new mobility symptoms or new bladder symptoms? What other questions should they be asking?
Yeah, so sometimes it's understanding if it's from a relapse, or sometimes it's progression, or sometimes it's things unrelated to MS altogether. Unfortunately, in men, for example, prostate issues are very common, especially as we get older. And so understanding and getting checked out for prostate things, so could it be something outside of MS? Maybe, getting checked out for those things, I think, become a must sometimes. And then I think the other piece around it is sometimes it's hey, like I got these symptoms, what can I do about it? And, the drugs themselves may not be, something that would have prevented that, but, there's symptomatic drugs that might help with trying to make quality of life better. So, Impera is something that, we sometimes forget about and don't bring up too often, but that's something that can sometimes make some people work better. It's not a miracle drug, but about a third of patients maybe find it helpful in kind of getting a little bit more endurance out of their walks or things like that. Muscle relaxers we use a lot. So especially if you're having spasticity or that tightness that's so common in MS, can be very helpful. There's devices that can be used to try and extend that. So nerve stimulators such as Walk8 or Bioness, or the muscle stimulators such as Psionic, Neural Sleep, can be helpful. Getting a good AFO or a knee brace to try and prevent hyperextension. These are things that, from an adaptive perspective, that sometimes we're not experts at, but that's why we work as a team and trying to kind of get to the right people that might be able to help, with some of these things. Same thing with the bladder is just getting people to talk to urology, and there's more things like bladder stimulators and things like this that I know very little about. So getting people to the experts, I think, is important.
And you brought up spasticity. Why does painful spasticity occur in the hands, and what can be done if muscle relaxers and anti-inflammatory medications don't help?
Yeah, so spasticity occurs wherever damage has happened. And so, especially in the spinal cord, it's very common to kind of see that, or even, after strokes or things like this that might affect the brain as well. So, uh, there's something about how the nerves rearrange themselves that you end up with this extra tightness associated with it. So predominantly, we tend to see it a lot more in legs because leg weakness is much more common than hand weakness, but we can definitely see it in the hands. And we're much more aware a lot of times of our hands and our feet, so you can kind of see it sometimes there. But sometimes, if predominantly the damage was to a hand or something like that, then that's where the damage part would occur to it. Um, so, if that sets up the case, then you want to think about trying to do muscle relaxers, a lot of stretching if you don't want to, if you're not tolerating them or things like this. And stretching is one of those tricky things because it doesn't last for very long, right? You don't have to do it for very long, but you might need to do it like every hour, every 2 hours to kind of get a good stretch in and kind of help improve some of those things. And obviously, you know, two things are better than one. So if you're doing stretching and muscle relaxers, that tends to be a little bit better as well.
Dr. Shah gave the tip once of tying stretching to at least every meal time. So you've kind of got a reminder to do it throughout the day.
Yeah. Yeah. And it becomes
Um,
really important to do it in the morning, I think, especially because after sleeping, that becomes kind of one of the times where you're really tight. And then towards the evening, because it just, as you wear out, it tends to become much more common towards the end. So that tends to be the pattern as you kind of wake up with spasticity, kind of gets better, and then it starts to build up back up again.
what about anything else like massage, acupuncture, lasers?
Um, I've heard of acupuncture helping, dry needling helping some. I think massage is helpful because it's almost kind of like a form of stretching. I am less familiar with some of the other things, lasers and shockwave therapy and things like this. Um, can be a little bit harder. For specifically the hand, there are some devices that can kind of help extend fingers. I have one patient who's tried it, but in MS, in upper motor neuron diseases, which includes MS and things like stroke and things like this, especially in the hand, forming a fist can be a little bit easier than trying to extend out the hand. And so sometimes the gloves kind of help sort of pull the fingers back. They have sort of a mechanism that allows you to do that. And then you're kind of like pulling in from the hand, but it kind of provides a little bit of support to kind of try and extend the hand. And it becomes an important thing to do because otherwise you can develop contractures. So, if you're having such bad spasticity and your hand is always like this, eventually that hand will tighten up into a fist and it can become really sort of just stuck in that position. So beyond sort of feeling better, it becomes really important just to be able to do that stretching to try and prevent that, especially in the hands, but it can be also a thing in the ankles and the foot.
Changing gears just a little bit, quite a bit, is PIRA, progression independent of relapse activity, the same thing as smoldering MS?
Maybe. So smoldering MS has been used to define inflammation um, that is not quite the inflammation that we see for a relapse, but that is associated with more of a slow process that might be seen in progression. Progression can maybe also include a degenerative component. So, smoldering MS might be part of the progression that we tend to see. Um, And so, what exactly is smoldering MS is the challenge because there's been a few different things that have been sort of associated with that. In the past and during the Ed Summit, we talked about pearls or these lesions that are associated with paramagnetic rim lesions, but things like slowly evolving lesions are probably different things associated with smoldering MS. Now, these things lead to disability, and that process is progression. Progression is a component of worsening. So worsening trying to kind of imply the non-MS part of getting worse. So by definition, this is kind of, the tricky part. So smoldering MS is trying to describe things that are making things a little bit worse that we can maybe look at and are getting better understanding of how to do this. Pira is, if you want to think about it, there's no difference between Pira and anything else beyond progression. But Pira has been sort of how we call it when we measure it for a clinical trial. So if that helps a little bit, um, but Pira is
Yeah.
progression.
Okay. Um, can you discuss late onset MS, kind of uh, what's different about being diagnosed over 50, and whether or not patients diagnosed over 50 should be looking at starting medications?
Yeah, so MS is a highly variable disease, and so we will often describe, I think it's something like 5% of patients get diagnosed under the age of 18, and about 5% of patients get diagnosed over the age of 60, with the average age being around 35. And so that kind of gives you a really wide spread as to, what that looks like. Age has been tricky because you will see people saying like, "Oh, it's a good thing to get diagnosed when you're younger," and sometimes people will say it's a good thing to get diagnosed as you get older. The difference there is entirely about perspective and how you ask the question. So if you say, "What will you look like in 5 years?" If you're getting diagnosed at the age of 18 and you're looking at being, 23, it would be, you know, when you're younger, you tend to recover from disease better. Uh, and so, in that situation, it might be better for the 18-year-old than it might be for somebody who's getting diagnosed later, where recovery, you're closer to having used up some of that reserve already, can make it really difficult. If you ask the question instead, how will you look when you're 60 years old? Well, if you're getting diagnosed at age 55, you don't have a lot of time to accumulate stuff. So, that's a better way. If you're diagnosed at 18, you have a lot of decades to accumulate disability. So by the time you hit, that age of 60, you can be really disabled by that point. So I personally think that being diagnosed later is a good thing. Fewer years of dealing with us, fewer years of drugs and things like this. So, I would take that. Um, the other component to this, as far as starting medication, is this: how long have you been stable? So it's very different to kind of recommend for somebody who is 55 and just got diagnosed at 55, don't start treatment because you're 55 versus if you are, for example, diagnosed at age 20 and now you're 50 and you've been stable for 20 years. So in that situation, I might recommend that 50-year-old who's been stable for a long time, hey, it's probably okay to come off drug. But for that patient that's newly getting diagnosed, I want to have some years of stability. And again, it could be that there's still a chunk of people getting diagnosed when they're 60 or 65 that fall in sort of that other tail. So there's a few things beyond age. We concentrate on age because it's easy to talk about, but the length of disease duration, the stability of being stable becomes, an important factor in that discussion as well.
Um, what about folks who were diagnosed midlife? What do we know about MS as they age? Um, are there special considerations for switching medications or expectations as someone ages with MS?
Yeah, so after you've been stable for a long time, and you're starting to age out, you might be able to stop treatment, as we were just talking about. I think the other piece that happens as we get older is we tend to accumulate disability. So, as disability accumulates, your body's first line of defense often becomes, which is probably their most important defense against infections, becomes breached, if you want to think about it. So, bladder function is a good one, right? If you're starting to have a urinary tract infection and you empty your bladder out really well, it's hard to accumulate an infection. You're just going to get rid of that infected urine, and you can kind of flush it out, if you will. The challenge becomes, if you're retaining urine, then that's going to feed the next urine, it's going to feed the next urine, and so it has a chance to sort of expand and make it worse. So usually if you have bladder dysfunction, you're kind of set up for more risk of infections. So a good indicator for that is disability. And if you're wheelchair bound, needing a walker, it probably indicates that there's going to be damage to some of our natural defenses that allow us to fight things for that. So you're at higher risk. Additionally, as you get older, your immune system is not as good. That's the good is that sometimes means you don't need to be treated for MS because your immune system can attack you as well, but it also can attack those infections. So by staying on the same drug as you get older, you start to kind of lower and lower that immune system because it's already lowered from age. And so then you're trying to balance those things out. And so as you get older, the risk of infections goes up. The benefit of the drugs, because of how helpful they are from an inflammation perspective, goes down because you don't have as much disease activity. And so that balance starts to tilt in the sense of, hey, you may not need drug or you need less of a immunosuppressive drug, something that's a little bit safer to do that. So that's where the stopping versus de-escalating sort of therapy discussion occurs.
Do BTK inhibitor drugs have a risk of PML?
I would say theoretically they do. The question, as far as I'm aware of, they've not had a case yet. But if you do sort of inhibit those B cells, which is part of the reason they were looked at and developed, theoretically there could be a concern. And we worry a lot about theoreticals in our field, unfortunately. That would not be the biggest risk that I would think about and worry about with these drugs, right? I mean, the number one thing we need to worry about BTK drugs is the liver issues, which are very real when you first start the drug in the first 3 months. There appears to be a signal for issues there, and we need to be very careful about monitoring things once the drugs become approved.
What are the risks or benefits of taking Ocrevus or any of the B cell infusions without the Solu-Medrol?
Yeah, so Solu-Medrol is often used as a pre-medication along with Benadryl and Tylenol. So most of the reactions that occur again are related to the stuff that those B cells release. And so with that first infusion, there's a lot of B cells, and therefore they can release a lot of stuff. So I would say at the beginning, it's helpful to probably use a lot of these pre-medications. Over time, if you're tolerating things well, we've been weaning these off, you know, somewhat on some patients with their risk of like, hey, how willing are you to potentially have an infusion reaction? And if they're okay with that, then we do the infusions faster. We try to eliminate the pre-medications and that kind of stuff. It's a little bit of a concern for patients who are diabetics or pre-diabetic because it can increase your sugar. So in a couple of patients that have bad diabetes, I try to take the Solu-Medrol off preemptively as well. So I have a number of patients that don't need it. A lot of our providers will try and do this. So we don't stick to it. There's a national shortage of Solu-Medrol right now, so we're doing it probably even more so and trying to save that Solu-Medrol for people who might need it more, for example.
Yeah. And how long can you go between infusions of Ocrevus, BMB, or Rituxan?
Yeah, this is a tricky question because it depends a little bit on sort of how you are doing as a patient, and where you are at with your MS. I would say from a safety perspective, there's no concern for having to do things. There's no rebound concern. So this becomes a true issue, for example, with natalizumab, where I probably wouldn't go much beyond about 7 weeks. We go anywhere from 4 to 6 weeks. We've tried to go at 8 weeks, and at 8 weeks, we start to see issues. But if you push it and something happens where you can't get infused, then you start to kind of push it a little bit more so. So at least from a safety perspective, from a rebound perspective, that's not a problem. I suspect the question is more around sort of extended dosing and how far can you get away with some of these things. Um, the the data is not great beyond a year, meaning we don't have a lot of patients that infuse less frequently than every 12 months. It looks like for at least up to a year that it looks like a pretty safe thing. Again, I wouldn't necessarily do that up front, but just as the disease becomes more stable, the risk of uh, relapses goes down, I would start to kind of consider that. I would do that especially sooner in patients who are starting to have, some concerns for infections, for low antibody levels, or things like this, where you start to kind of push it out a little bit more so. Um, the There was a trial that we had where patients either got placebo or a dose of rituximab and then went on Copaxone, and it took about 2.5 years for that disease activity to kind of get back to that seen with the placebo uh, benefit to that. So if you're on other drugs, or things like this, which isn't usually the case for this. So I kind of feel comfortable a lot of times going out to 2 years, at least 18 months. But that data is very kind of sparse. Uh, yeah, 9-12 months is a common extended dose interval.
And just to um, clarify, what I heard in there also was if for some reason you can't get your infusion right at 6 months from traveling or being sick or something, that shouldn't be a huge stressor for patients.
Correct. That's exactly right. So I think that's one of the nice things about B cell depletion is you have a lot of flexibility. A lot of times when we're talking about drugs, you're kind of trying to um, match when the drug levels start to decrease. Here we have the drug levels decreasing, but then you're waiting for those B cells to kind of come back. Even if the B cells start to come back, for some reason in MS, it seems like the drug continues to work within that time period. So it doesn't seem to match up very well with that. So you have a lot of flexibility.
Thank you, Dr. Alvarez. With that, we'll turn it back over to Dr. Schreiner, Gross, and Kmeyer.
Thank you.
So we'll start with question number one. Can you talk about MS lesions versus other brain lesions, and how do you differentiate what can cause non-MS lesions? This is a great question. So lesion is just a non-specific word. We can have lesions, anywhere in our body. You can have a skin lesion, a liver lesion. When we talk about brain lesions, we typically see them when we do our MRIs, and they show up as these bright spots. We have to kind of look at them and as experts and people who've seen lots of these things, does it have the kind of pattern that we expect to see when we look at the brains of people with MS? So there's a particular shape of the lesions that they might have, and a particular distribution, certain parts of the brain or the spinal cord that are affected that we tend to see with MS. But it's still not perfect in terms of being able to distinguish between MS and non-MS. And there are certainly some spots that may be very small that we might say, I guess that could be an MS lesion, or it could be a non-MS lesion. So we're trying to develop additional tools to kind of help us with that, distinguishing that. And that's actually going to be incorporated into, we're going to have new diagnostic criteria coming out for MS, hopefully shortly. And some of that takes into account certain characteristics that some of these lesions might have, including what's called a central vessel sign or central vein sign. The idea being that you can actually do particular types of MRI sequences and look for a little tiny blood vessel going right in the middle of one of these lesions, and that is supposed to be more specific for MS. And so if you see those, or if you see a bunch of those, then you can be more confident that we're talking about MS as opposed to one of these other conditions. So what are these other things that can cause spots in the brain? Well, lots of things. Actually, as it turns out, even just getting older, people can develop little spots in their brain. People who suffer from migraines can get some spots in their brain as well. Processes that affect the smallest vessels in the brain. So usually we think of like kind of chronic medical conditions, high blood pressure, cholesterol, diabetes, cigarette smoking, things like that can all lead to, well, they are all actually risk factors for stroke, which is also a same process of kind of blocking blood vessels in the brain. But before that, and less dramatically, you can just get like little spots that appear in the brain from those conditions. And so part of our job is trying to determine, are we dealing with something more like that, in which case we might go down that pathway, or does it look more like MS? And so, that's in a nutshell how we deal with it. Question number 2. Does a family member with MS give any indication of my own possible progression? A little ambiguous with the question, if the questioner actually has MS or not. If they do have MS, then no, there's not really a great correlation or any correlation between how bad a family member's MS is and how bad your MS might be. And those, they can vary, widely. In terms of, if you don't have MS and you're asking what is your likelihood that you could get MS, well, we know that MS does have there's some genetic susceptibility. So a first degree relative of somebody with MS has something like a 2 to 4% chance of developing MS in their lifetime, which means most people won't in that situation. So we're talking about, of course, first degree relatives would be like your parent. One parent has MS, then you have like a 96 to 98% chance of not having MS.
And Rob, if I may, I can jump in and say, like, what are the things that affect like your course of disease? So we believe MS is one disease, and yet people have different experiences, some being quite severe, some being quite mild. And there are multiple lifestyle things that can influence that course of disease. So whether or not you're a smoker, if you have comorbidities that can worsen your overall health, that might worsen your disease course as well. And we know that other things, like whether you're obese, we know obesity is a pro-inflammatory state. And so that may play a role as well. And so when you think about MS as being one entity with multiple different things affecting it, you can see how one person in a family might have one experience, but another person in the same family could have a very different experience.
Yeah, to add to that, I think seeing kids, one of the first things I ask them in talking about the diagnosis of MS is, who do you know anyone with MS? Because it's we as human beings, like, we like to understand diseases from the perspective of what we've seen around us and from the experiences that other people have had, especially those close to us. And so if someone has a family member with MS, it's very tempting to think like, oh, well, that's what it's going to be for me. But like you said, there's so many factors that go into like what someone's experience individually with MS is going to be. One of the things I always point out that's important is a number of times, like, especially when it's older family members, like, their experience with MS is coming from a place when maybe there wasn't the same immune therapies that we have now. And so, like, what happened with their MS, with their progression, if they develop progression, like, that may be a very different experience than what people newly diagnosed will have.
Yeah, it's well said. It's kind of like when people tell me, when I ask about their family history, like, oh yeah, I have grandparents who had heart attacks when they were in their 50s. And, I don't typically delve into that more deeply, but, back in the day, almost everybody smoked cigarettes, often like 2-3 packs a day or whatever. And so, that was almost certainly influencing that generation's risk for cardiovascular events. And so, just, looking at it simply as a genetic predictor is, like you were saying, that, Terry, there's a lot of other factors involved, and especially, early use of disease modifying therapies with people who are diagnosed now.
Well, to build off of that, I saw one of the questions asking, how do I know when it's time to try a pharmacologic solution versus a lifestyle modification? And so, this is a question that comes up a lot. And, what is the best way to help treat my MS? Like, what can I do to protect myself with my MS? In general, we recommend disease modifying therapies for almost everyone with MS, with the exception of if someone was coming in, meeting us for the first time and they were older and their disease hadn't been active for a number of years. We talked about discontinuation studies on other webinars and education summits. But in general, like, we do recommend an immunotherapy, a disease modifying therapy for people who have MS. We know that lifestyle modifications, so not avoiding smoking, secondhand smoking yourself, having a generally healthy diet, exercising regularly. We know that those are all great things. They decrease the inflammation, they do decrease the risk of relapse, they help decrease the rate of brain atrophy. That was a presentation at the last Ed Summit as well. But that usually doesn't protect you as much as you need protecting. And so we know that with the immune therapies, especially some of the highly effective ones, that these do the best job in combination to help decrease relapses, to protect brain health, to prevent atrophy. I can give some examples. Again, Dr. Schreiner and myself see kids. Like, we often see kids who have like very moderate or severe inflammation on their brain MRIs when they first present. A lot of them are extremely active. Most of them have good diets. They're not smoking. Like, clearly, like, the exercise diet alone didn't protect them against that. And so, without the disease modifying therapies, there's the risk for flares, there's risk for, increased brain atrophy rates, there's risk for subclinical inflammation kind of leading towards progression. So lifestyle modifications are great, and they do support your brain health. They do help with MS. They help with so many other things like related to MS, like fatigue and cognition. Like, they definitely are things that are needed to be implemented together. I do have some patients who, really want to try just lifestyle changes first. If we do that, like, it's a conversation, like, what are the risks of doing that versus starting immune therapy, because there's risk with either side. And usually we decide to monitor things really closely. So doing MRIs like every 6 months at least, to kind of see over time, are there any new lesions? Are there any signs of, active inflammation occurring? And we usually come to an agreement too, like, if we start seeing new lesions, like, we should start the immune therapy. So I have had some people kind of choose that as kind of their option. And we find ways to make sure that we're monitoring safely if that happens. So I don't know what your experience has been,
But
Dr. Schreiner.
typically, it's not. I was just going to say, typically, it's not an either or, right? I mean,
Mhm.
I think Dr. Schreiner and I agree, with those things about, about a balanced diet, regular physical activity for sure. But, for most people, that would be, in combination with their immune therapy. You do them both together, and that gives you the best chance at leading a healthy, functional life.
Mhm.
Yeah,
And
I
I
agree.
can take
Do
a little
doing
bit.
both.
Yeah, I can talk a little bit more about diet, because I know there were several questions about diet. And then I'll look to my colleagues to add details as well. So one of the questions is, what is the ideal diet? And it's something I love talking about, but it's also something that is really challenging in some ways to answer, because there are many different diets out there that have been purported to be the MS diet or the anti-inflammatory diet, or, you know, this diet to treat autoimmune disease. And so inherent in any study of diet is the difficulty that the people involved in that study have to be strictly adherent to the diet, which is really hard to do on a human level. And so there are some, I look at all of those studies with just a little bit of a caveat. Was anybody in the study, or was everybody able to sustain the diet over a period of time? And then what was the longest period of time that was achieved? And can we really make any conclusions about how an outcome of that diet may be a result, or may be valid? And so I don't know if there is one diet. There are diets that have been better studied than others, and one is the Mediterranean diet. And the Mediterranean diet includes whole foods, lots of seeds, olive oil, minimal processed foods, minimal meat. And it actually does involve a glass of wine, if you read the description, per day. And that was another question that came up, like, is mild to moderate wine intake okay? And I'm going to say probably a little bit of wine is okay, but everything in moderation for sure. So the Mediterranean diet has good evidence. Some of the more recent diets that have been studied include the keto diet and the intermittent fasting diet. And those were some other questions that came up. And these actually have been studied in MS, at least a little bit, perhaps more keto diet than intermittent fasting. And there seems to be some benefit. Now, it hasn't been tied directly to like relapse prevention, but what the studies have looked at is, do these people feel better? What are the fatigue measures? What about the cognitive, like, self-reports and energy levels and sleep? And those kind of subjective measures have been improved while on the keto diet and with intermittent fasting. The problem with keto diet is that it's kind of hard. It is a strict diet to adhere to that can have some social implications for sure. Dining out on the keto diet is pretty doable, but challenging. And so there may be a moderate, sort of compromise. And this is what I recommend for my patients, which is know where your food came from, like be able to list the ingredients, be able to pronounce them, work on hydration, work on increasing vegetable intake, strive for 5 every day. And so this type of like step towards a healthy diet may be the most sustainable and still with benefits overall. And so I'll turn to my colleagues and see if you have additions to that answer.
Yeah, no, I think that covered it nicely. I'm always curious how people define moderation in terms of drinking. You heard the one about moderate drinking is drinking less than your doctor.
Well, for me, that would be 0. So
yeah, right, exactly. I think the more we learn about alcohol, it seems that it's probably not as safe as not that we thought it was particularly safe, but there were a lot of things that came out like in prior decades that suggested that we should all be drinking like a glass of wine a day. And I think a lot of that is getting walked back lately, that it's like, well, actually maybe as humans we probably shouldn't be drinking the alcohol that we are drinking. So not necessarily specific to the MS, but no, yeah, definitely echo what you said about diet, especially some of these restrictive diets that can be really hard for people to sustain. And so yeah, we don't have like a whole lot of like the highest level of evidence to support this or that. I was just looking up about intermittent fasting before we tape this, and it looks like there have been a few small studies. Some ways of intermittently fasting seem to be a little bit more palatable, I guess you would say. Like when you forget how they called it, but it was like timing TRE. which stands for, give me one moment.
Yeah, there's some forms where you just don't do it for a period during the day, and then there's
Yeah,
some
that's
forms
it.
where you like don't do it for like a couple days and like a
So
given
it's
longer time period.
right, the Ramadan type,
Mm.
time restricted eating. So you're typically not, only taking in calories within like a certain time interval every day. And that seems to be a little bit more easily achieved, I think. But what Dr. Schreiner was saying was true, is that, we've really, we have some evidence to suggest that this might impact things like, how a person feels, maybe their weight. If they're overweight, it'll allow them to lose weight. But a lot of these things, and especially we've got a lot of questions here about, the potential for remyelination. And I'll just point out that we don't really have a great test to measure remyelination. There are some things that we are working on in the research realm, but a lot of these diet studies aren't looking at that specifically. And so when we're talking about, whether this, makes a person feel better, a lot of that is just, we do surveys and we ask people, do you feel, how do you feel now? How do you feel now? And maybe measuring some of the different blood components of things and looking for signs of inflammation and whatnot, but not specifically, myelination or remyelination, because that can be pretty hard to measure still.
Yeah.
Anything else to add?
Well, I was just going back to like the diet and that. Yeah, I agree with like alcohol. I think more and more, my sense is too, like it's kind of redefining what was said in the past on like, oh, you need, a little bit is helpful. And now it's like, well, kind of any amount can be harmful. And so it's always a balance on like, what enjoyment you might get from a drink here or there versus, what the risk is. And we know that with alcohol, I think any amount, like it can increase like the risk for brain atrophy, which we've talked about before. Red wine and, some of its benefits, I think in the end, the resveratrol, which was the compound that was supposed to be really beneficial and like anti-aging in red wine, ended up needing like 100 glasses of red wine a day to get the amount that actually showed effects. So that is definitely outside of moderate, and definitely more than your doctors. But I think diet and exercise in particular is something that there's an opportunity for us to talk or help more with. Like we just did a survey of like a few hundred people with multiple sclerosis and kind of asked what they needed kind of the most help or support or education around. And like over 50% wanted more help with lifestyle modifications and like talking more about exercise or diet and like more specifics about that. So I'm glad that we have this opportunity to talk through some of that.
Yeah, for sure. Okay, going back, looks like we skipped over one about pseudo relapses. There's actually, I know I did a talk earlier that should be recorded on the MS Center website about pseudo relapses, but essentially the question is asking, do they cause damage? Well, by definition, no, we don't think that they cause damage, and that's kind of how we're trying to distinguish them from relapses or the type of events that we think are associated with new inflammatory damage to the central nervous system. And we think it's useful to distinguish between these two because pseudo relapses can happen usually in the context of like an infection or increased stress, poor sleep, things like that, where a person will experience kind of their old MS symptoms becoming more prominent. And then when that kind of external provoking factor is removed, then the situation kind of returns to normal. If that can happen kind of to anybody, regardless of what disease modifying therapy they're on or whatever, and so we wouldn't necessarily want to make any kind of adjustments to their treatment plan because of that kind of thing happening, versus if we're seeing new damage show up on a person's MRI, for instance, and they're having new clinical symptoms suggestive of an MS attack, then that would mean we probably should change their medication, that whatever we're doing is not enough to stop that damage from happening. Okay. Any
Maybe touch briefly on this question about perimenopause and menopause in women with MS. And I will say, just touch on it briefly, because I think that there are a lot of hormonal changes that happen around that time. But the way I think of it is more of a disruption of homeostasis. Like, because of these changes, your body is changing. What is like status quo and, you know, normal for you is changing as all of these other changes occur. And so it may be around this time that things that you've had because of MS, fatigue, cognitive slowing, or brain fog, they get worse. And it's not necessarily, in fact, I don't think it is that the MS is getting worse. It is that because this homeostasis is getting rocked a little bit, that is bringing to light, it is sort of accentuating some of the things that have occurred before because of the MS. And so I think that it's real. I think, like so many things in life, and certainly in MS, it's multifactorial. But if you are experiencing new symptoms around that time, and I'll just throw out like 50s, late 40s, you know, talk to your MS doctor for sure. And also, you know, talk to your primary care doctor, who can run blood tests to actually figure out where your hormones are and whether or not that is in fact the cause of some of these symptoms that can be coming from different places as well.
So what you're saying then is maybe it's kind of similar to you know, the logic of a pseudo exacerbation.
Mhm. Yeah.
Okay,
Yeah.
maybe more prolonged.
Not something new happening with the MS, but the symptom is real. And the task in front of you is to figure out, is it appropriate to be identifying this symptom to a change in hormones in perimenopause or menopause, or is there something else going on? And this is where we can partner with your PCP to help figure out and make sure we're not missing something else.
We have a question here about psilocybin, and then I think there's also one later on about ketamine, and I'm going to lump them together because for one, I think we don't really know a whole lot about them, especially like kind of in an MS context. But I know that especially ketamine now is being investigated in you know, a mental health disorder, severe kind of refractory depression and things like that, as a possible treatment. And I think, you know, psilocybin, this is I think the active ingredient, a hallucinogen in like magic mushroom type things. That's also being looked at as a potential treatment for some mental health things. So I don't think we know enough. Certainly, we wouldn't be able to, you know, say that it is remyelinative in any way. And so, but perhaps we'll learn in 5 years or 10 years that it does work in that way. But
Yeah. Yeah, that's what I found too. I hadn't found any evidence for psilocybin for remyelination, kind of in any like even animal models. You know, there's been questions on that and like neuroplasticity. And so I think that might be kind of like where that question was brought up. You know, studies are still ongoing with that, and there's other ways to have neuroplasticity, like through physical therapies, occupational therapies, and those things. For ketamine, I agree. It's definitely being used in like depression, pain. Like there's different ways that it's used clinically right now. There have been a few studies I saw that have found potential benefits for fatigue. And there's one phase 2 study that's at Johns Hopkins that I think is going to finish this year. Like they plan their end date as like mid 2025. That was going to look at ketamine for fatigue and MS. So we'll see what the results of that are. Like ketamine has, you know, some of those useful properties. It also has side effects. Like it's dissociative and anesthesia, and so it's something we'll have to see what the side effects are too. You know,
definitely needed to be done in a monitored setting, right?
oh yeah. And so, and you know, another question kind of related to that, like on the fatigue aspect. You know, one person asked, just is it normal to find just thinking to be fatiguing? And and it can be like is some person's experience with MS. When we did that survey recently, like over 50% of people were having issues with fatigue as part of their MS. There was I think at Summit last fall that I talked a little bit about fatigue, and I had one of my friends who has MS join to kind of talk about her experience with MS. And a lot of what she talked about was cognitive fatigue, just, you know, not necessarily the physical fatigue, which is related, but can be separate, but just like the difficulty of like slowness of thinking or kind of going through and having that reserve. And there's a lot of potential reasons for that. Like some of it can be the stress of having a chronic medical disorder like MS, or like having to think about appointments and self-monitoring of other symptoms of MS can take a lot, like mood, sleep, all of that can be part of it. There can also be just fatigue, we think, related to the lesions from MS, like with some of the connections within the brain being maybe a little bit less efficient or needing to take kind of that plastic route around some of the lesions, like that may take more energy and may kind of require more to do kind of like the same thinking. So there's a lot of thoughts on like why that might happen in people. And our usual approach is when someone's having fatigue is to think about all those other causes and see if there's things that we can help with sleep or mood or other things like that. And there are some medicines that we sometimes try as well, although a lot of times like lifestyle changes and thinking about those other things work as well or can work better.
Let's move on. So we have a question here about incidence of MS in first responders and or those in the military. So wondering if MS is more prevalent in those populations, and they suggest a few reasons that could be, high stress, sleep deprivation, etc. The thing is, I don't know that is true. In fact, I don't think it is necessarily true that MS is higher in those groups. And so it's a good idea, or it's a good, good some suggestions there, but I don't know that we have that data to back that up.
Yeah, I agree. I don't know of data around that issue.
Yeah,
I found one study that had it at least higher in the military. But again, that was one study from before. So and I don't know if it's necessarily related to some of the things that
they're exposed to.
Yeah, or that they were kind of wondering about. It looked like it was, an increase, but it wasn't maybe a dramatic increase to say, it's exposure to a chemical or anything in particular.
Yeah. Okay, next, please discuss risk of breast cancer with Ocrevus. Mother died of breast cancer, and now I'm over 65. Is the risk higher for me? So it's a good question. Ocrevus or ocrelizumab, which is one of our B-cell depleting immunotherapies. Initially, when it first arrived, there was some question about risk of cancer, specifically breast cancer, because I believe a handful of individuals in the kind of pivotal clinical trials over a decade ago were diagnosed with breast cancer during the time of the study. To me, I think that ended up just being like a statistical fluke. We know that breast cancer is very common, that I think something like 1 in 8 women will be diagnosed with breast cancer in their lifetime, which is a crazy number. And so screening for breast cancer, with regular mammographies and so forth, I think that's, very important for women. And I think that's true whether you're on Ocrevus or you're not on Ocrevus. I think the data since Ocrevus has come out, which was in 2017, so about 8 years ago, the company has a program that's been keeping track of, the cases of cancer. And it doesn't seem like there's, population-wide an increased risk, people on Ocrevus versus people who are not on Ocrevus of breast or any other type of cancer. And so yeah, I would recommend just kind of, regular cancer screenings as would be age appropriate. Okay, moving on. Should we talk about GLP-1s?
Sure.
So these are becoming increasingly popular now. These medications, like Wegovy, semaglutide. So these are used to treat diabetes, and they can promote weight loss. And so the question is asking about their possible benefits versus risks in an MS context. And I think, this is an area that is, again, I'll say we don't know enough about. We know that, just people taking them in general, from my experience seeing people who've been on them, including not just patients, but family members and others, it does seem to help with weight loss. They are pretty effective in that respect. There can be some side effects, a lot of potential for like GI discomfort and that kind of thing. I don't think we know whether they have specific benefits to MS, or if their benefits might be mediated by just like improved overall kind of health and decreased weight and so forth. And so
And again, like fat can be pro-inflammatory itself, so there may be some sort of overall benefits to lowering the inflammatory burden. But again, I don't think that we have enough data, and I think there's still a role for disease modifying therapies for sure. We are not anywhere close to saying that one could be used instead of the other.
yeah, so when somebody asks me about that in the clinic, I usually refer them to their primary doc and say, I don't have a particular problem with it, but that's a conversation between you guys, and if they think it's appropriate and then they want to prescribe it, then that's fine. Okay, we have a question about vagal nerve stimulation. Okay, so this is a treatment modality that has been used for some time to treat people with epilepsy, so people who have uncontrolled seizures. And now it's being looked at as a possible adjunctive treatment for MS. In fact, we have a study ongoing right now with one of our colleagues, Dr. Bennett, who's looking at not the implanted form of vagal nerve stimulation, but a transauricular, so around the ear version of it, to see if it helps improve symptoms in people with MS. So let me see here. I'll share the flyer for folks who are interested. Okay. So it looks like the study is ongoing, 6-month time commitment, 3 times a week study visits in the first month, followed by single follow-up visits at month 2, 3, and 6. And here's the contact information down at the bottom if you are interested in that. But interesting idea. We'll see if it works. And okay, are there more objective ways to diagnose PPMS based on pathophysiology? Okay, PPMS, or primary progressive MS, is one of the subtypes of MS. Most of the time when we diagnose MS at the beginning, we're diagnosing relapsing MS or relapsing remitting MS. That's something like 85 to 90% of the time. And the remaining time we're diagnosing primary progressive MS. The difference mainly is that people with relapsing MS start off with a relapse or an attack, which is a kind of a sudden or somewhat abrupt change in their neurological function. Whereas the minority of people who have primary progressive MS, it's much less sudden. It's a more gradual decline in their function, especially as it involves walking, balance, that kind of thing. And so, to me, it's all one disease, but it does manifest differently in different people and even over the course of time in the same person. And so there's the other type of progressive MS, secondary progressive MS, is traditionally when somebody starts off with the relapsing form and then gradually over time transitions to this secondary progressive form of MS. But in terms of Ways of distinguishing, there's not great ways of distinguishing. It's mostly based on the clinical presentation, what the story is, and kind of how they look, on the examination and so forth over time. We're looking to try to find ways, MRIs or other biomarkers that can distinguish between progressive and relapsing, and maybe, due to a certain extent, progressive MS tends to have more predominance of disease in the spinal cord, although certainly people with relapsing MS can also have lesions in the spinal cord. So there's a lot of overlap, I guess is what I would say. Okay. 17, is it possible or common that you never relapse again if you do continue DMTs throughout your life? Yes, certainly. It is very possible. In fact, we have a lot of patients nowadays where we start them on a treatment, particularly like a high efficacy one, and they don't go on to have further relapses or episodes. Now, the part of the question that says for the rest of your life, we can talk a little bit about that, and we have already. But we don't think necessarily a person needs to be on a disease-modifying therapy their entire life. There's probably a certain point at which it's not really doing you any benefit anymore, and at that point, we talk about potentially doing a trial off and seeing how things go, and frequently that goes fine, and then a person still doesn't have any further attacks or exacerbations. But yes, it is certainly very possible for that to happen nowadays.
Yeah. I think similar to that, someone had asked about the comparing rituximab and ocrelizumab and like their effectiveness, and they're very similar in their effectiveness. And in practice, if we're trying to put someone on one of the anti-CD20 therapies, we'll go with kind of what insurance allows us to, and be happy with that if we're able to get one of those. I think personally, of all my patients on rituximab or ocrelizumab or anti-CD20 therapies, I think I only have one that I can think of who had flares after they had started these and had really gone into it. And I think, most of us have like one to a few people that we can think of who have maybe had those.
The B cell therapies, so at the current time, that includes rituximab, ocrelizumab or Ocrevus, ublituximab or Briumvi. Those are the three that are all IV. And then the other one is Kesimpta or ofatumumab. That's a subcutaneous injection. To me, they're pretty interchangeable in terms of their effectiveness, which is to say they're all very effective. And yeah, it does often just come down to, little things like, which is going to be the most accessible, insurance wise, or if you've tried one and maybe had an adverse reaction to it, maybe we try a different one and it works out a little bit better, that kind of thing.
I think the one difference, and Dr. Gross, I'm not sure if you practice this way too. I guess if someone has progressive disease, then I might be more likely to go towards ocrelizumab, just because the trial included and kind of looked at that, so you can get more specifics. But in theory, they should be very similar in that regard. And I don't know if you wanted to say more about that, because I think overall you probably see or have seen more progressive patients than Dr. Schmieder or myself.
Yeah, that's a tough question. There may be, and I think, we've got studies that are looking at this now, a slight benefit in terms of dosing these anti-CD20 therapy, the amount of B cell blockade that you get, and how frequently in the dose and so forth, and that could differ between these things. But I would think more so between the 3 IV forms and the subcutaneous version, which is at a much different dose than the IV. They're all different dosages and they're all slight differences, chemically. But you're right that, Ocrevus is the only one that has had an actual study in primary progressive MS, and that did show some benefit in terms of modest, but some benefit in terms of delayed progression. And so, yeah, it might even also be an issue with insurance there too, is that if somebody has primary progressive MS, then that's the one that will be most likely covered. But yeah, I don't know how different they are from one another. Okay. Anything?
Well, why don't I just take a stab at the
Okay.
frexalimab one?
Sure.
That
Yeah.
was a question about what is this therapy that is under investigation called frexalimab. And this is something that is targeting one of the ways in which white blood cells communicate with each other, called the CD40 ligand. And by blocking the CD40 ligand, this medicine sort of impairs the immune system from getting into a pro-inflammatory state. And so there is some thought that this will be an effective therapy, perhaps with chronic inflammation, and that's the smoldering MS. But we don't have the results of those yet. So this is something on the horizon. We're all looking towards the future to see whether or not this turns out to be something that could be used for this, particular indication.
Yeah. We have studies ongoing that are enrolling for that, both in relapsing remitting MS and secondary progressive MS. So reach out to us and we can consider getting you in if you're eligible for one of those.
You want to talk about vitamins, maybe?
Yes. Yes, that sounds good. So we have a question about vitamin D, or it's possibly about vitamin B12. We're not sure. I'll start by saying, we've been looking for like the vitamin that will be useful in MS, and I don't think we've really found it yet. The majority of research on vitamins, I would say, probably has been on vitamin D, although we've looked at a number of other ones. And with vitamin D, there was actually a really nice paper that came out recently out of France that found it with folks who were kind of recently diagnosed with MS prior to starting disease modifying therapy, randomizing them to either receiving high dose vitamin D or not, that the people who got the vitamin D did have a better outcome in terms of, delayed having another attack kind of thing. So we know it does have some immunological function that could potentially be beneficial in MS. I think the issue is just that, how much of benefit, and I think it's probably fairly mild. I don't think it's as beneficial as something like, say, Ocrevus or one of the highly effective immunotherapies. So I don't think taking it by itself is likely to be enough for the most people. And so yeah, I usually recommend it as kind of if you're going to take a vitamin or a supplement, that's the one that has got the most evidence behind it, kind of thing. Vitamin B12 is a vitamin you might hear about. Vitamin B12 deficiency is something that has been linked to different symptoms, including neurological symptoms, some of which can potentially mimic MS, but not necessarily. Having low vitamin B12 doesn't necessarily predispose a person to getting MS, and we don't necessarily think that supplementing with B12 improves a person's MS per se. I would say that if somebody does have low vitamin B12, then certainly taking a B12 supplement makes sense. There are conditions where a person can't properly absorb, an autoimmune condition that a person can't properly absorb vitamin B12. And so that might, also lead to low vitamin B12 and that kind of thing. But yeah, so we're still trying to find the kind of the vitamin or mineral or supplement that'll really help folks with MS, especially, as a lot of you have questions about remyelination. That would be really great if we could find something like that.
Mm-hmm. And as we run out of time here, I wonder, Dr. Kammeier, if you want to take this question about Lhermitte sign.
Oh, sure. So I think it was just asking what is causing Lhermitte's and how can you get rid of it? And so this is a great question. Like Lhermitte's, for people who haven't heard that term before, or is kind of, especially with like bending of the neck, having like this electrical kind of shooting sensation that might kind of travel downward or kind of travel on that location. And we think it happens especially when there is a lesion So some demyelination that's happening in the spinal cord, like in the area of the neck. And, those nerves are not necessarily firing in the same way. The signals aren't being conducted kind of in the same way. And when you move your neck, you're actually causing a little bit of traction or a little bit of stretching kind of on those nerves. And so that causes them to misfire. And that can cause those kind of abnormal sensations. So for some people, like it may show up just when they've had an attack recently and like that was a new lesion, and so over time like that might decrease. I've seen some people where it sticks around and it's something that they kind of continue to notice even after they've maybe recovered other ways from that flare. There are things that we can do to try to help with it. So there are different medications for like nerve pains, neuropathic pains that are sometimes helpful. So I've tried that for some of my patients, and it'd be helpful. I'm not sure, Dr. Schreiner or Dr. Gross, if you've kind of found other things, but those are some of the things I know that have worked the most for my patients.
I would second that. I also think a tincture of thyme is really helpful, as this tends to at least soften some of those intense vibratory sensations can be muted over time and occasionally dissipate. But of course, that's really hard to bank on when you're the one experiencing the unpleasant sensation.
Real quick, we have a couple questions from kind of family members of people with MS, and kind of, what's the best way of dealing with their family members' MS. I think, there's definitely a role for you to kind of support your family member, encouraging them to, check in with their MS provider. And especially if they're somebody who may be like older or like have more limited mobility or something like that, making sure that they have like all the resources they need at home, somebody to help them if they need it with like, cooking and pills and things like that. Is this a situation where the person may be better off not living at home anymore if their condition is more advanced? Things like that, being around, being part of that conversation and helping the person come to a good decision about that can be of help too. You don't necessarily need to weigh in on all the nitty gritties about like specific medications. You can hopefully leave that to the patient and their doctor, because that's what we're here for. But yeah, being there for support, I think, can be very, very helpful. Even if you're not necessarily there, like in person, you live in a different part of the country or whatever, but being available, by Zoom or whatever, so that the person knows that they have some backup.
Thank you for your time, doctors, and thank you to our viewers for all of your questions. Please make sure that you're signed up for our mailing list in order to receive notifications about upcoming education programming. Thank you.